of food, for example, carbohydrate and fat in the maintenance of the health or as a nutrient. Now I'm continuing with the leftover part of the fat or lipids, wherein we talked about that fatty acids are needed, triglycerides are not that good, and trans fatty acids and saturated and unsaturated fatty acids, we all discussed about it. Leftover part is simply to tell about the unsaturated fatty acids, whether it is monounsaturated or polyunsaturated. Monounsaturated means single double bond, and polyunsaturated means, am I audible? Am I audible? Okay.
Yes, sir.
Fine. Monounsaturated fatty acid is
Yes, sir.
preferred over polyunsaturated fatty acid, for the reason that सुनाई नहीं दे रहा है, आवाज नहीं आ रही है? आ रही है, fine. Because in polyunsaturated fatty acids, it is the free radical formation which becomes more dangerous,
Yes, sir.
and it results into the oxidative products or peroxidized reaction products that are deleterious for the health. And polyunsaturated fatty acid source are fish oil, wherein omega-3 fatty acids are present. And now something about the trans fatty acids. We listen quite often in around us, and in the literature also we find that trans fatty acids are not good for the health. Why they are not good? Because they are also unsaturated and they can be useful, but they are not useful. For the reason that unsaturated fatty acids behave like saturated fatty acids in the body. And the reason is that unsaturated double bond is in trans configuration. And cis configuration is okay for the body, but trans configuration is not. You will see it in the book. You can read it in the book, how trans and cis are different. Trans fatty acids are also harmful in terms of raising the serum LDL cholesterol level, but they don't affect or influence the high density lipid cholesterol level. They increase coronary heart disease risk, and for that reason, trans fatty acids are not recommended, not useful. These trans fatty acids are found in small amounts in animal fat. Bad reason in the which is non-vegetarian or eat meat, and with fat rich portion of the meat product. Trans fatty acids are formed during hydrogenation of liquid vegetable oil also, that is in the formation of margarine and partially hydrogenated vegetable oils. So there also you run into trouble, and you find that these trans fatty acids are formed during the hydrogenation process. Major component of commercially baked or deep fried goods such as cookies, cakes, and deep fried fruits in our Indian style, whatever we eat or find to eat in market as snacks for the sake of snacks, they all might be rich in trans fatty acids. Something about the dietary cholesterol. We somehow find cholesterol in our diet also, but it is found only in animal fat. If we are taking too much of the animal fat, then only we run the risk of having the dietary cholesterol. The effect of dietary cholesterol is less important than the amount and type of fatty acids consumed. The effect is more related to type of fatty acids that we consume and the amount of fatty acid that goes with the triglycerides or the form of the fatty acids. And this is the recommendation that dietary cholesterol should not exceed, or the cholesterol content in the diet should not exceed 0.3 grams per day or more than 300 milligrams per day. That is the limit. This is the table I have borrowed from a book. Main tissue is some non-vegetarians' favorite dish, but that also runs very high in butter and ghee and meat and fish. They are all within limits of the intake. Milk, of course, has some, but it is very little or negligible. Now, other dietary factors affecting coronary heart disease is the alcohol, and this is in the books. It is reference books. It is described as a good part, and it is consumed globally in the form of the drinks. It's not recommended. Alcohol abuse and potential dangers. So beware. This is not recommended. But of course, in the books you can find the information regarding it. And there's a positive correlation in moderate alcohol consumption and plasma high density level cholesterol level. There's a positive correlation. If you take more alcohol, HDL-C level may also increase, but that is a good part. Red wine may also provide cardioprotective effects in addition to alcohol content. It has phenolic compounds that inhibit lipoprotein oxidation. So in a way, it is beneficiary. Red wine is beneficiary and people recommend it globally. But of course, because of the alcohol abuse is strongly not permitted in India and in our society, not recommended. Now we come to the part of the protein, which is also required in our diet. And of course, the quality of the protein is most important. This quality concerns with the essential amino acids that are obtained from the protein which we take up or ingest. And there are 9 essential amino acids are needed out of 21. 9 are essential ones, and they are needed for tissue repairs. So unless we have adequate amount of essential amino acids going into our food, we may not have good kind of repairs in our good quality enzymes or proteins or structural proteins, or so many factors. They are all requiring correct type of amino acids, and some of them have even the requirement for the essential amino acids. So the quality of the protein should be such as which provides essential amino acids. And quality protein, as I said, ensures essential amino acid supply. Gelatin is a very common protein people use in market or in commercial purposes, but that is deficient in amino acid, essential amino acid. Please keep in mind. And the quality of the protein is determined by this method: protein digestibility, corrected amino acid score. So this is something which is technical and is not needed to be described or written in the question which is asked in the exam. Protein from animal source of high quality, which is readily digested, and this is meat, poultry, protein from poultry, milk, fish. They all contain essential amino acids. Regarding the quality, again, proteins from plant source are of lower quality than animal protein. Remember that also, because most of the vegetarian people, they suffer from this, and they mostly take vegetable protein, which comes in the form of vegetable or pulses, which we eat, but they are all vegetables, and this is of lower quality. For example, in wheat, lysine is deficient. Wheat is deficient in lysine, but it is rich in methionine. And similarly, kidney beans are rich in lysine, but deficient in methionine. So for that matter, whatever we eat for dinner or lunch in terms of chapati or roti or bread and kidney beans, which we call rajma in our society, they have different types of amino acid enrichment. Wheat is rich in lysine, but kidney bean is rich in lysine. Why wheat is deficient in lysine. Combination of plant proteins with animal proteins is therefore recommended in the food or in the diet, because partly they support or they provide the deficient variety of amino acids. Then we come to the part of the nitrogen balance. What is nitrogen balance? It is the amount of nitrogen consumed which equals to the amount of nitrogen excreted. So then the body is supposed to be in the balanced form, and it has, I mean, in the nitrogen balanced form. Nitrogen excreted in urine as urea, in sweat and feces. So it's a constant process of excretion of nitrogen, and has to maintain the balance of the nitrogen. Healthy adults are normally in balance of nitrogen. Whatever they consume, the nitrogen consumption in the form of amino acids, it is equal to the excretion of nitrogen in the form of the urea. Positive nitrogen balance means nitrogen intake exceeds the excretion part. This is called positive nitrogen balance. If the nitrogen intake exceeds the excretion, then it is a positive, and it is seen in tissue growth. And positive balance of nitrogen is also seen in childhood days or in childhood period, in pregnancy, during recovery, in emaciating illness also. Sometimes, people think of becoming very lean and thin, and that is the emaciating process, and it is an illness. And there also, you lose nitrogen. But in the recovery, a positive balance is is maintained during the treatment part. Further, also occurs in inadequate dietary protein intake. Suppose sometimes people don't believe in protein intake; they mostly believe in vegetable, and whatever protein comes through the milk or a small amount of wheat, they feel satisfied with it. But that is not correct. And then one runs into the negative nitrogen balance side. So one has to provide, people go on fast, and for 10 or sometimes a week, or during our holiday time, I've seen people prefer to starve for a longer period of time, then it can create deficiency of nitrogen balance. For maintenance of nitrogen balance, you satisfy the need for nitrogen intake to maintain nitrogen balance. That means you satisfy that you ensure that you take protein in your diet, and obligatory nitrogen loss via urine, feces, or skin has been estimated to be about 3.5 grams of nitrogen per day per normal body weight person. This obligatory loss is equal to loss of about 22 gram protein. You see, this is obligatory. You are going to lose 22 gram protein every day. So you need to take up filling amount or 22 gram or 50 gram of protein per day, at least. That is recommended also. But this it has to be more than the obligatory loss. To compensate for loss, you require intake of about 1 gram of nitrogen per kg weight of good quality protein. So much of the milk what we take. And maintenance nitrogen balance is applicable to infants, children, adolescents, and during pregnancy, during lactation, and convalescence, that means during recovery period. As the growth stops, the protein requirement also decreases. This is a very simple equation. When there's no growth, there's no requirement of protein. Now, regarding the human requirement, the requirement of the dietary protein depends upon biological value of dietary protein. Biological value is calculated by formula, which I will tell you later. But greater the proportion of animal protein in diet, lesser the amount required. So if you keep the animal protein, for example, a glass of milk all the time in your lunch or dinner, then of course you need less amount of the protein, because most of the time protein is supplemented, or even the essential amino acids are supplemented through the milk. Recommended dietary allowance for adults is about 1 gram per kg body weight. So that means you need 56 gram protein if you are a 70 kg person. So at least 50 gram of protein is needed by every individual. It is recommended dietary allowance. People exercising strenuously and regularly, or athletes, they are by professional athletes, and they want to make muscle mass, they need 1 gram. So it is little bit more or 20% more. So that means you need about 60, 70 gram protein if you are a 70 kg man. Pregnant and lactating women also need 30 grams in addition to their basal requirements. So 56 grams is the required per person. Now these during pregnancy, women during pregnancy and during lactation need at least about 90 or 80 grams of protein per day. Infants are to consume only 2 grams per kg per day. So that is the data which you have to remember. And recommended daily dietary allowance for protein has been listed in this table. Infants need about 2 grams per kg body weight per day. Children up to 10 years need less than 2.4 gram or about 1.75 gram per kg body weight per day. During adolescence, you further decrease and you need only 1.6 gram per day per kg body weight. Girls need similarly 1.4 gram. Adult men, half the amount. And during pregnancy, it is again back to the same what is recommended for the infants. And in lactation, during lactation also, mothers need to be given 2.5 grams, just like the infants. They have to be fed protein as per the recommended RDA value. Now the question is that why don't we eat a lot of proteins? But the literature says, or the scientific evidence suggests that consumption of excess protein gives no advantage. Whatever is recommended, only that much has to be taken in the diet. Excess deamination and resultant carbon skeleton, they will be simply shunted to form acetyl coenzyme A or provide more energy. So from that, but then again you will excrete more of the nitrogen, you generate more of the nitrogen during deamination process. So that may damage the body. So for that reason, only the moderate or the required or recommended amount is to be taken. The reason for avoiding the excess protein intake is that its elimination often accompanies the calcium loss in kidney. So if you take too much of the protein, you excrete a lot more protein than the normal case, and that results in the loss of the calcium, leading to risk of the nephrolithiasis, that is the formation of a stone in the kidney, and osteoporosis. These are the reasons why excess protein intake is not recommended. Protein sparing effect is nothing but it's a process by which body derives energy from sources other than protein. That means body doesn't want to use protein for getting the energy, so it spares the protein and uses the other nutrients, fatty acids, dietary fats, and carbohydrates for generating the energy. Protein sparing conserves the muscle tissue because muscles need more protein, and in order to make the structure of the structural protein synthesis, for example, collagen, etc., elastin, collagen, all the myosin, all these kind of proteins need to be preserved. They need to be spared for energy. From that point of view, only fatty acids, dietary fats, and carbohydrates are enough. Amino acids are not catabolized for energy. For energy requirement, body needs only the fatty lipids or the carbohydrates. Besides that, we also need micronutrients. And the micronutrients are nothing but the vitamins, minerals, essential trace elements. Minerals are needed, calcium, magnesium, iron. These are the minerals needed in more quantities, but there are certain essential trace elements. For example, molybdenum, selenium, zinc. These are also very important macromolecules which are needed for the growth of the body. These micronutrients participate in functions of enzyme, structural and signaling proteins, and they are required in less amounts. So their lesser intake is needed. Main function of these macronutrients is whether They work as antioxidant. They build infrastructure. For example, zinc. Zinc changes the structure of the protein to make it to work as a good transcription factor. Cell signaling. Some of the molecules are needed for cell signaling. And this is for signal transduction part. Now, the amount of the macronutrients which is recommended, you see in the list, the table I've listed, it's also borrowed from the book, from the, what you call, Vasu's book, Vasudevan. Thiamine, there's no upper tolerable level if you look in the extreme right column, but mostly it is the estimated average requirement EAR value and recommended dietary allowance RDA value. Thiamine B1 as per the RDA or EAR value. Similarly, riboflavin, vitamin B2, that is vitamin B6, they are all as per recommended dietary allowance. And it's all listed in the book of biochemistry. Pyridoxals are not listed. Pyridoxamine similarly not listed, but they are needed by the body, but you cannot take it exogenously or in the diet. Vitamin B12, again, it is very essential and it is recommended as per EAR value or RDA value. Folic acid is needed, for this tetrahydrofolate reductase function. And pantothenic acid is needed. And pantothenic acid requirement was discovered by our Institute of Nutrition in Hyderabad, Indian Institute of Nutrition in Hyderabad. They reported the essentiality of pantothenic acid. So Indians have contributed into the list of macronutrients needed for the body. Biotin also needed, and it is as per the adequate intake value. Choline, similarly, vitamin C as per EAR and RDA value. And there is a upper intake level described for vitamin C. Vitamin C cannot be taken blindly or in any amount because it can create free radicals in the body, and that can damage or create oxygen radicals and can damage the various cell components, and that way they can damage the tissue and the organs function. These are the lipid soluble vitamins A, D, and E, and K. They are also needed and recommended dietary allowance value, and vitamin K as per the adequate intake value. And there is dietary tolerable upper intake level described for these vitamins. Similarly, now the macronutrients for this boron, calcium, chromium, copper, fluoride, iodine, they're all needed as per the RDA value. Chromium is needed as per the adequate intake value because chromium works as a part of the glucose or insulin receptor. So if you fall short in the chromium level in the blood, your insulin receptors may not work. So most of the diabetics are given formulations which has in it adequate amount of or permitted amount of chromium. Copper is also needed. Fluoride ions are needed. Iodine is needed, of course, for the thyroid hormone. Calciums are needed for bone, and boron similarly for the skin. Iron, magnesium, manganese, molybdenum, nickel, phosphorus, selenium, vanadium, and zinc. You see, selenium, zinc, vanadium, molybdenum, these are manganese, they are trace elements. And they are all needed for the sake of the nutrition. This is again available in the book Biochemistry in the nutrients chapter. Okay, now we go to the change. We close this and we go to another. Now we move to the part protein energy malnutrition, or PEM. This is malnutrition resulting due to less intake of protein. And this is an important chapter. And in amino acids, and they need to synthesize proteins for the body growth and the muscle development and the growth of the organs. So if the intake of protein is less, or the building blocks or energy coming from the protein is less, then it will influence the recovery of the patients. Protein malnutrition, what it is? It can be uh, undernutrition, it can be overnutrition, or it can be inadequate intake of macronutrients, and any diet-related non-communicable disease. You see, malnutrition can be, in case of undernutrition, can be wasting, or that means the uh, height to weight ratio, or low weight and versus height. So that kind of outcome occurs in case of undernutrition, stunted growth, underweight. Overnutrition, of course, causes overweight and obesity, and inadequate intake of macronutrients results into the deficiency of vitamin and minerals, and diet related non-communicable disease also occur, and that is simply NCDs are described nowadays. The hypertension and the diabetes, cancer, they're all related to the dietary uh, intake or malnutrition. Malnutrition is prevalent globally. It's everywhere in the world, not only in India, but everywhere in the world. And overweight and obesity, overeating affects globally about 2 billion people. Underweight, eating less or becoming thin, it affects drastically less amount of people, and that is mostly because the poor countries which cannot afford or which don't have good governance to provide food to its people. But that is only 25% of the overweight value. See, a lot of people are more obese and overweight as compared to underweight. Undernutrition is more prevalent in India, according to Indian Council of Medical Research. And in India, this is the highest in the world, undernutrition part. In India, about 48% are with the stunted growth, and 19.8, roughly 20% are with wasting. That means low weight for height. They have a good height. The bone structure is good, but the muscle mass is not that much. And this is solely because of the malnutrition. 50% are stunted. That means they don't grow properly if they don't get food. In India, overnutrition, much less. 34.8% are underweight, 20.4% are overweight. Overnutrition is much less because most of the people, half of the population is underweight. 35%, one-third population. This is the statistics of India and the world. And 45% of deaths in under 5-year age children is caused by undernutrition. This is interesting, or causing concern that almost 45%, almost 50% under 5-year children die because of the undernutrition. So for that reason, information or your knowledge regarding it while treating a patient is important. Now we come to the protein energy malnutrition or protein energy undernutrition, PEU or PEM. What it is? PEM is mostly defined as acute malnutrition. Protein energy malnutrition is acute form of malnutrition and is measured in terms of weight by height, ZS score. What is the height and what is the weight? And the relation between that is considered to be the procedure for measuring it. And mid-upper arm circumference value, MUAC value. In the upper arm, in the mid area, you measure the circumference and you decide whether it is moderately malnourished or it is severely malnourished. So MUAC value, that is mid upper arm circumference, if person has 115 centimeter to 125 centimeter, it is considered to be moderately malnourished. But if it's less than 115 centimeter, then it is considered to be severely acute malnourished person. These PEM patients or protein energy malnourished patients have decreased appetite, or they show decreased appetite or high catabolic rate of nutrients. They metabolize the nutrients very fast, but they don't feel like eating. Patients hospitalized, it is also seen in patients hospitalized due to major trauma or infections. If somebody is coming with the gastritis or major trauma and hospitalized, and they don't feel like eating, then there also malnutrition is taking place. Malnourished children also show this protein malnutrition. Or elderly group, for example, in old age, people don't feel like eating, they lose appetite, but this is not correct. They need to have proper intake of food. Then PEM patients, if they don't take orally the food, then they require intravenous or parenteral or internal tube-based administration of nutrients. What are the causes of the protein energy malnutrition? Obviously, inadequate intake of protein and or energy, that means in terms of fat or in terms of carbohydrate. That causes the malnutrition. Symptoms: depressed immune system with the low ability to resist infection. They often fall victim to infections, diarrhea, very common, flu, virus infection, tonsillitis. This type of things happen if person is malnourished. And it's also seen in the subjects, in PM subjects, death often occurs from secondary infection. This is very common factor in malnourished subjects because they don't have a good buildup of the immune system and they cannot fight the infection, so they fall prey to the infection, and of course, the death may occur. There are two extreme forms of malnutrition described. That they are very prominent ones. And the first is the Kwashiorkor disease, and the second is marasmus disease. Kwashiorkor disease, children look with a, they have a swollen belly and pot type of belly. And in marasmus, they look very skeletal. You can see in some pictures which are showing the African children. In Africa, it is very common, but in India also you can see Kwashiorkor and marasmus. These two are very prominent forms of malnutrition. In Kwashiorkor disease, there is a protein deficiency, but adequate calorie intake. For example, carbohydrate and fat intake is adequate, but protein is somehow not supplemented in the diet. Protein deprivation is greater than reduction in total calories. They have whatever calories they need in terms of fat and the carbohydrate, but the protein is not that much in their food. Severely decreased synthesis of visceral proteins. For this reason, the visceral protein or whatever protein is needed for the organs, visceral organs, they will not be of that much potency, of that much goodness. So the Kwashiorkor is a term from localities Ghana. This word comes from the Ghana country, and what it means is, just for your knowledge, older child gets sickness when next child is born. That's what it means. When the child becomes 5-year-old and the other child comes, then it gets sick. On the birth of the second child, first child often falls sick. This is Kwashiorkor disease, and this is because of the less protein intake. It is commonly seen in developing countries. Like now, India is not developing country. It is now getting into the more economically strong countries, but still parts of the population have this kind of malfunction, malnutrition disease. It is usually seen in children that are less than or 1 year age, and in children diet containing mostly carbohydrate. In some communities or some families or some part of the country, people usually give them more of the carbohydrate. But protein deficiency will make them Kwashiorkor type patient. According to World Health Organization classification, how to find kwashiorkor patient, it is by describing or finding out the body weight percentage of the standard body weight. Suppose 5-year-old child has to have a standard body weight, then what is the present body weight of that child and what is the percent of the standard body weight? That way, the WHO has classified that a child can be termed as a kwashiorkor or malnourished child. In kwashiorkor, again, symptoms are stunted growth. You can see skin lesions, depigmented hair, anorexia, fatty liver, or enlarged liver, edema can be seen. These are the symptoms, clinical symptoms, and decreased serum albumin level. In the blood examination, you will see low amount of the albumin because it cannot be synthesized. Albumin is synthesized in the liver. And if you don't have the good amount of protein intake, albumin level will go down. Edema results from the lack of the adequate blood proteins to maintain distribution of water between blood and tissue. You see, you need adequate amount of blood protein to maintain distribution of water between blood and tissue. I will tell you later in my lectures regarding the extracellular matrix. And this is the matrix in between the cells, which makes so many functions or which makes the other cells to grow with each other and transfer their signals in between them. But if there's no adequate amount of protein or blood protein, edema may result because of it. And there may not be proper communication between the two cells and in the matrix which occurs between the two cells. Chronic malnutrition reflected in the level of serum albumin. As I told, albumin is synthesized in the liver. So if you don't have proper intake of the protein, chronic malnutrition will be seen, and this can be reflected in terms of serum albumin level. Dietary selenium supplementation can cure the disease. This is a treatment, part of the treatment, but here in symptoms, you can alleviate the symptoms if you have selenium content in your diet. Nowadays, people have started getting concerned with this essential trace element, and they take it in the form of the various health supplements. It is available in the commercial pharmacy sectors. Marasmus is another malnutrition PM disease or PEU disorder. It is basically a continued severe deficiency of dietary energy and proteins. In this case, Marasmus child, you have deficiency of both carbohydrate or energy providing macromolecules and the proteins. Both influence it. Protein deprivation is greater than reduction in total calories, like kwashiorkor. Here, protein more both carbohydrate or the fat and the protein deficiency create marasmus, and that's why the body of the marasmus child looks like, you know, very, very thin and skeletal. It is commonly seen in developing countries like Africa and also, and in children that are of age less than 1 year. Seen in children put on breast milk supplemented with watery gruels. You see, this is seen in Africa mostly, and there African families provide or give them some watery gruels. It's sort of, you know, some carbohydrate-rich vegetable which is boiled in water and supplemented along with the breast milk to the newborn children. But the watery gruels have a lot of carbohydrates in it and therefore carry more of the calories. So native cereals deficient in proteins, and they provide calories, more of the, they provide less of the calories also. Gruels don't have enough amount of the nutrient-rich material in it. Symptoms, but symptoms are the arrested growth, extreme muscle wasting, and loss of subcutaneous fat. Like emaciated skin, that means fat disappears underneath the skin and it shows simply the skeleton and the thin skin. Weakness and anemia, of course, uh, seen in these subjects. No edema. So there's no edema in these people. And classification of malnutrition is done as per the WHO guidelines. And body weight, you see, I told you, according to WHO guidelines, body weight percent of the standard body weight is described for each type of malnourished disease. Kwashiorkor, for example, if the body weight of the child is 80 to 60% of the standard body weight, it can be as Kwashiorkor disease child. Edema is seen of a small grade, and deficiency weight for height. That means what we call I mean, there's a change or deficiency in the standard height and weight relationship. If that is also seen, then it is kwashiorkor. Marasmic kwashiorkor. Then go to marasmus. Here you see less than 60% body weight of the standard body weight. Then it is a marasmatic child. No edema and deficiency in weight for height is also seen. That is a wasting. Wasting is seen, and high content of wasting, that is deficiency in weight for height. Nutritional dwarfism is seen when the body weight is less than 60% of the standard body weight, and underweight child is, of course, if the body weight is 80%, 60% of the normal body weight, then it is underweight child. Features of marasmus and kwashiorkor, you can see here. This is from the book, Vasudevan. Age of onset is, in case of marasmus, it is less than 1 year. But age of onset in kwashiorkor is 1 to 5 years. Remember, meaning that when the first child, next child is born, first child becomes sick. So naturally, there's a difference of about 1 to 5 years in between the two. And the onset is, of course, therefore later in the kwashiorkor disease. Deficiency in marasmus is the calorie, and in kwashiorkor is the deficiency of the protein. Cause in case of marasmus is early weaning and repeated infections, and in kwashiorkor it is a starchy diet after weaning precipitated by an acute infection. So marasmus, repeated infection make the child die, where in case of kwashiorkor, acute infection creates creates mortality. Growth retardation is marked in case of marasmus, and it is seen in kwashiorkor disease. Appearance is normal in marasmus, but anorexia nervosa, that means loss of appetite, is seen in kwashiorkor disease child. The skin is dry and atrophic in case of marasmus. The atrophic means it keeps on, decaying and going out or falling off from the skin. And but kwashiorkor has crazy pavement dermatitis due to peeling, cracking, and denudation. The skin is more lesion filled. It has more of the lesions in the skin. Here, in case of marasmus, no characteristic change, but in case of kwashiorkor, spare, soft, and thin hair is seen. Other associated features in case of marasmus is nutritional deficiency, watery diarrhea, muscles are weak and atrophic. In case of kwashiorkor, angular stomatitis, that means inflammation, small cracks in one or both corners of the mouth, that is stomatitis, angular variety. Watery diarrhea and wasting of the muscles. This is seen in both the disease. Serum albumin level, of course, is also marker. In case of marasmus, it is 2 to 3 gram only, but in case of kwashiorkor, it is less than 2 grams. Serum cortisone is increased in case of marasmus and decreased in case of kwashiorkor. But in case of marasmus, nitrogen balance will be negative if it is increased. What biochemical alterations seen in PEM or PEU? The biochemical alterations seen in these protein energy malnourished cases are the hypoalbuminemia, or the low level of albumin, poor wound healing, and edema seen. So this is a biochemical change which you see in case of undernourished or malnourished, especially with respect to protein intake. Hypoalbuminemia, albumin low level, and in this case, albumin less than 2 gram per deciliter is seen in biochemical estimation. Then immunoglobulin G increases due to infections, because you will fall prey to infections and you will get more infections. Seen in this PM disorder, fatty liver due to decreased lipoprotein synthesis. Hypoglycemia may be seen in marasmus. You see, glucose will also be seen low amount because in marasmus you take low calorie food. Hypokalemia and dehydration seen during comorbidity of diarrhea. Calcium loss of low level of calcium also occurs, and dehydration also is a common cofactor in case of comorbidity of diarrhea. Hypomagnesemia, magnesium level go down, is a usual finding. These are the biochemical changes that take place, and now the result of protein energy malnutrition. What is the outcome is that in early life, if you see protein energy malnutrition, it may be reversible and persistent malnutrition may impair intellectual capability. These are some of the changes. Corrected, moderate, and mild forms may not show these results, but they are the usual outcomes. Now, for the treatment of malnutrition, what is recommended is that in early life, it may cause physical and functional deficits. This I told you already. For treatment, you need to provide 150 to 200 kilocalories per kg body weight and 3 to 4 gram of protein per kg body weight in the diet. So calorie intake of the recommended part, 200 kilocalories per kg body weight, remember, not per body or per child. It is per kg body weight. So for a 10 kg body weight, for a 10 kg child or 5 kg child, you need 1,000 calories. Diet is needed. Providing diet is needed. 3:1 ratio should be maintained for the vegetable protein and animal protein. Bengal gram peanuts can be used in vegetable protein, and milk is of course needed for animal protein. And monitor disappearing of edema and rising serum albumin and weight gain. That is important to monitor if you want to give a good growth to the child. Now, cachexia is another disease or disorder, which is a muscle wasting disorder. Here you lose appetite and muscle atrophy is seen that cannot be reversed by conventional nutritional support. It is seen in chronic disease such as cancer, CPD, chronic pulmonary disease, or chronic kidney disease. Cachexia, that means loss of appetite and muscle. How to assess nutritional value? This is something which maybe I will now take in the next lecture. Here I will stop. So, because it's already more than an hour for our lecture. So, in next lecture, I will cover this. How to assess the nutritional value of proteins. Okay. So, thank you. Bye. इसको बंद कर दीजिए. Close it.
और पड़ोसी
सारी कहाँ बैठे, बाथरूम में हो क्या?